Hello everyone, this is Dr. Chandana Vishwanatham. So today in this video I'll be talking about respiratory system from Mrcp part 1 and part 2. The topic for today is pleural effusion. This is very small topic and there are few MCQs that have been asked from this topic. So mainly you have to remember the causes of transitive and exudative pleural effusion. Transitive pleural effusion is when the pleural fluid protein concentration is less than 30 grams per liter and exudative is greater than 30 grams per liter. So transitive effusions are mainly because of congestive heart failure, the most common cause, and then constrictive pericarditis. And there are various causes of hypoalbuminemia, such as chronic liver disease, nephrotic syndrome, or malabsorption, which can all these can result in hypoalbuminemia, and they can result in transitive pleural effusion. And hypothyroidism is an important cause of transitive pleural effusion. Peritoneal dialysis and uremia are the other causes. And the exudative causes include infections, mainly pneumonia and tuberculosis. And there are some other infections such as subphrenic abscess causing a right-sided exudative pleural effusion. And connective tissue diseases such as rheumatoid arthritis and SLE and neoplasias, not only lung cancer, parenchymal cancer, but also mesothelioma or lung metastasis can also cause an exudative pleural effusion. Some other causes such as pancreatitis, pulmonary embolism, Dressler syndrome is where there is post-myocardial infarction, pericarditis and pleuritis, which can cause an exudative pleural effusion, and yellow nail syndrome. Some drugs such as methotrexate and nitrofurantoin, these can be the causes of exudative pleural effusion. So the main thing that you have to know in pleural effusion is the analysis, the investigations, which the clinical features can be dyspnea, non-productive cough, chest pain. This, as you may know, you may be knowing this one, reduced expansion, dullness to percussion, reduced breath sounds will be there on examination. This is a very important case for PACEs also. They will put pleural effusion case and they'll ask you the most likely underlying diagnosis, underlying cause for the pleural effusion. They may ask you like that. In that case, you need to search for some clues in examination, such as if the patient is having the carcinoma of the lung as an underlying cause, the patient will be having nicotine stains on his hands or clubbing, lymphadenopathy, radiation burns, and if there is any carcinoma of the breast that is causing metastasis to the lung, there can be breast lump or nipple changes. And if the patient is having any rheumatological condition, then you can look for any clues to the rheumatoid arthritis or SLE. And you can, if you are expecting a transitive type of pleural effusion, if the effusion is on both sides, it's bilateral, it is more likely to be transitive. So in that case, you can look for any evidence of chronic liver disease such as jaundice, ascites, peripheral edema, any stigmata of chronic liver disease. And if the patient is having hypoalbuminemia, the patient would have an cachectic look. Poor nutritional status and peripheral edema can be there. And if the patient is having congestive heart failure as an underlying reason for his effusion, he can have a raised jugular venous pressure, third and fourth heart sound, and the peripheral edema can be there. So in that way you can look for the clues to the etiology and diagnose the case in PACEs. So even if you tell if it is a pleural effusion case, you'll get most of the marks. But if you tell the etiology, underlying etiology, it could be this one or that one. In that way, you will secure more marks and you'll have higher chances of passing passing the exam. So coming to the investigations, the BTS 2010 advises patients to get a chest X-ray PA view, which is very easier to have a look at a chest X-ray and diagnose pleural effusion. There will be loss of costophrenic angle or the contour of the angle. And USG chest ultrasonography of the chest is mainly done to see if there are any septations or if there is need for pleural aspiration. Under ultrasound guidance, we can do that pleural aspiration. And CT chest and finally the pleural aspiration and analysis of pleural fluid is very important in differentiating exudative and transitive conditions. That criteria that we need to apply in these patients is Light's criteria, but it is also advised that if the protein level in the fluid is greater than 30, it is exudative, and if it is less than 30, it is transitive. But this is a usual rule, but if the protein level is between 25 to 35, that means there can be a overlap between transitive and exudative type of effusions. So in these cases, Light's criteria, it is better if you apply the Light's criteria rather than going just by the protein level in the fluid. So exudative is likely if at least one of the following criteria are met. The first one is pleural fluid protein divided by serum protein greater than 0.5, pleural fluid LDH divided by serum LDH greater than 0.6, and pleural fluid LDH more than 2/3 of the upper limit of the normal serum LDH. So these are the three important things that you need to remember in pleural fluid topic, because they can give you the pleural fluid analysis and ask you if it is an exudative or a transitive cause. The options will include various causes of transitive and exudative causes of pleural effusion. If you can calculate the Light criteria, then you can go ahead answering if it is a exudative or transitive. Based upon that, you can choose your option. So it's very important to know the Light criteria. But in patients on chronic diuretic therapy, this diuretic therapy can increase the concentration of protein and LDH in the pleural fluid into an exudative range. So to diagnose an exudative pleural effusion in a patient with chronic diuretic therapy, there is something called the serum effusion protein gradient, which is serum protein minus effusion protein, that should be calculated. And if it is less than 31 grams per liter, then this more correctly identifies an exudative pleural effusion in patients on chronic diuretic therapy. So that has never been asked till now, but it is better if you have an idea on how to diagnose an exudative pleural effusion in a patient with diuretic therapy. That can be asked as an MCQ. And there are some things that you need to remember. Pleural effusion with low glucose is rheumatoid arthritis or tuberculosis can be suspected. Raised amylase can be seen in pancreatitis or esophageal perforation, and heavy blood staining, that is hemorrhagic pleural effusion, can be expected in mesothelioma, pulmonary embolism, or tuberculosis. So this can be asked in the form of MCQs. And when do you place a chest tube to drain the pleural fluid is important. If the fluid is purulent or turbid or cloudy, then you have to put a chest tube immediately. And if the fluid is clear but the pH is less than 7.2, in patients with suspected pleural infection, a chest tube should be placed. It means even if the fluid is not turbid, based on the pH and suspicion of pleural infection, you have to put a chest tube to drain all the infectious fluid. If there is a recurrent pleural effusions happening, you can do recurrent aspiration, there's something called pleurodesis, and involving pleural catheter, and some drugs to manage the symptoms such as opioids to decrease the dyspnea. This can be done. And coming to the MCQs, this patient has a lymph node dissected from his neck for possible recurrent head and neck cancer, and his post-operative chest X-ray, he has moderate pleural effusion, which on aspiration drains white milky fluid. What is the likely diagnosis for the cause of his effusion? The options are empyema, mesothelioma, chylous effusion, reactive effusion, malignant effusion. So what is empyema? Empyema means frank purulent fluid is nothing but empyema, and there is nothing mentioned about the purulent fluid. That is white milky fluid. White milky fluid is different from purulent fluid. And mesothelioma, it is a pleural malignancy, but it can present with pleural effusion alone, but the history is not suggestive of mesothelioma. So usually they give a history of asbestosis exposure in the patient, so that is not there. And malignant effusion are usually can present with serous or serosanguinous fluid, but presenting with a white milky fluid is unlikely for a malignant effusion. Then the reactive effusion is also is not a cause of milky white fluid. So reactive effusions are usually lymphocytic infiltrates secondary to movement of the interstitial fluid. The underlying etiology is varied. It has many causes, but it includes usually the congestive heart failure or collagen vascular diseases. There can be causes of reactive effusion, but it is not white and milky fluid. And coming to chylous effusion, it is a white milky fluid aspirated on thoracentesis. So usually there will be history of cardiothoracic or head and neck surgery, especially excision of cervical lymph nodes, which can damage the thoracic duct and resulting in chylothorax. So this can be a chylous effusion, but to confirm the diagnosis, we need to perform pleural fluid, triglyceride, and cholesterol levels. So that will be diagnostic of chylous effusion. And this is also a similar MCQ where 71-year-old undergoes radical surgery of esophageal adenocarcinoma with this surgery and good recovery. And few days later is beginning increasing short of breath, the BP pulse is okay, and reduced expansion of the chest, dullness to percussion of left lung fields. This itself states that the patient is having an pleural effusion. And going to the investigations, the important ones here are there is large left-sided pleural effusion and milky colored effusion on the aspiration, and the protein content is 48 grams per liter. So the question they have asked is which of the following investigations of the pleural fluid is most likely to confirm the underlying diagnosis. So as I told you, that it is a milky white fluid and there is a history of surgery, head and neck surgery. So chylous effusion is highly likely because of the damage to the thoracic duct. So as I told you, pleural fluid, triglyceride and cholesterol levels should be done to diagnose the chylous effusion. So triglycerides would be the correct option here. The next MCQ is a 64-year-old man, and he has lost significant amount of weight over the past few months and now presents with increasing shortness of breath, heavy smoker, and decreased air entry on the lower chest and dullness to percussion. Chest X-ray reveals right-sided pleural effusion. Pleural aspiration is performed. Which of the following features, if present, would be most specific indicator of probable underlying malignancy? So malignancy, as I told you, in the causes of hemorrhagic effusion, malignancy was one of the cause in it. So that is one thing, and the other options, as you can see, heart turbid fluid or neutrophilic count, these are in favor of infections, and abnormal LFTs or abnormal pleural fluid LDH levels are not the most specific indicator for malignancy, but uniform blood staining throughout the pleural fluid samples is very specific indicator of malignancy. This can be the correct option, C. Another question is a 60-year-old South Asian patient presenting with shortness of breath, weight loss, night sweats, respiratory rate is high, lymphadenopathy, and stony dull percussion. His chest X-ray demonstrate moderate pleural effusion due suspect tuberculosis, as he confirms that his wife was recently diagnosed with the disease. And coming to the investigations, the important ones here are only the DSR 43 and CRP is 85 milligram per liter. And yeah, we'll go to the question. Which the following investigations is most useful in confirming the cause of the pleural effusion? So they basically want you to confirm active tuberculosis. So the key to diagnosis tuberculosis is a tissue sample, particularly so that PCR for tuberculosis DNA can be carried out to provide rapid diagnosis. So the main thing to confirm the cause of pleural effusion as tuberculosis would be CT, pleural biopsy, and tuberculous PCR. So tissue diagnosis in case of tuberculosis is very high yield to diagnose compared to other samples such as pleural fluid or quantiferum gamma, and high resolution CT alone can't help. There should be tissue that we have to take it from the pleura, so that it becomes easier for us to diagnose tuberculosis. Only based on CT we can't diagnose tuberculosis. So most useful in confirming the cause is pleural biopsy and tuberculous PCR. So this question, 54-year-old male patient presents to the general medicine clinic, 6 months history of slowly worsening breathlessness and is finding more difficult to carry out daily activities. He denies chest pain but has occasional cough, during which he brings up some sputum. Ex-smoker and minimal alcohol. Traveled to US last year. Has not been in contact with anyone known tuberculosis. Long history of working as an electrician since 18 years old. Has lately struggled with his work due to breathlessness and reduced air entry in the right lower lobe and slight general wheeze. grade 3 clubbing, chest X-ray demonstrate small to moderate right pleural effusion, multiple pleural plaques. Which are the following investigations more likely to differentiate between benign and malignant disease? So in this patient, there are things that suggest malignancy, because the patient has breathlessness, and is having ex-smoker. He's a smoker, history of smoking, and also there was grade 3 clubbing. So there is high chance that the patient may have a malignant disease, which is important to differentiate. So they are asking us which investigation is more likely to differentiate benign and malignant disease. As in case of tuberculosis, malignancy, also tissue-based diagnosis is very reliable one. So we will obviously go for the tissue-based diagnosis for this case. Pleural biopsies, yes, that I would say it can be helpful in diagnosis of malignant disease. So this is the correct option. Pleural aspiration, CT, left T, blood filling. These are not that important to differentiate the malignancy and benign diseases. So tissue-based diagnosis is again the option. So my upcoming videos will be on pneumonia and pneumothorax. So pleural effusion is usually a smaller topic compared to asthma and COPD that I have dealt previously. But you can get questions mainly on the life criteria, mainly on the diagnosis of exudative pleural effusion in a chronic diuretic therapy patient, and some causes of pleural effusion are also important, translative and exudative, and this is an important case for PACEs also. So it is better if you read now itself and get familiarize yourself with the pleural effusion cases in your wards. So okay, then we'll have a discussion about pneumonia and pneumothorax in the next videos. Thank you. Please subscribe to my channel and encourage me to do more such videos. And I have also uploaded some of the chest x-rays in my YouTube shorts. So you can go there and try to identify the chest x-rays, and in the same video itself, in the ending you will get the diagnosis. So you can have a look at those chest x-rays, which are important and very high yield for Mrcp part 2, because part 1 we don't expect chest x-rays, but in part 2 it is very important that you have to diagnose the chest x-rays. So thank you.